Who is hoping to present today, please?
Hello, madam.
Yeah, who is there?
Gihan, madam. I'm going to present, madam.
Okay, fabulous. You're ready, Gihan?
Yes, madam.
Give me 1 second. The others, I hope the others were intending to join. Has my dog taken this? Hang on. Give me 1 second. Okay, no problem. I found it. Right. So we have 29 people. Not great, but the only way to get on with life would be to proceed. Right, let me get the whiteboard. Kaviduni, do you think the others meant to join or they didn't want to join because today is a holiday?
The people said they would join. No one like informed me they won't be joining.
Okay,
I got
all right.
disconnected. I got disconnected from my one. That's why I'm calling from my roommate's son, madam. Sorry.
Okay, that's okay. All right. So just get rejoined and we'll get, let's hope Gihan is, thanks Kaviduni. Gihan, are you still with us?
Yes, madam.
Right, okay. So I've got the whiteboards ready. Now what I would like, this is the first time that you're doing a case presentation with me. What I would like is that the presenter would aim to finish. It'll take longer because I might make some corrections, but in an ideal world, your history, mental state exam and physical examination will all be done within a matter of say 5 to 7 minutes, okay? So that you have half the time left for anything further to be done, and I'll talk again about this shortly. I would like all of you to please try to concentrate on what Gihan is saying, because what would be useful for you is to jot down a few notes as he presents so that you can aim to develop a differential diagnosis, a problem list, and a management plan. Okay, so we'll do this practically and let's see how things go. Well, please start when you're ready, Gihan.
Okay.
Gihan, if you're ready, please start. No problem.
Okay, madam. Shall I start?
Yes, please. Yeah.
Mr. Ashen Satsara, 22-year-old unmarried patient, currently working as hybrid mechanic in private company from Chilau, referred from medical ward 45. This is the first presentation to psychiatric services following ingestion of 3 seeds of yellow oleander with 4 teaspoons of sugar. On history of presenting complaint, he is a known patient with cannabis consumption since 2015, and he was abroad for 3 months duration for
Gihan,
Yes,
Gihan,
madam.
I'm sorry. I'm just interrupting you once because the signal was not so clear. So he took 3 seeds of yellow oleander with several teaspoons of sugar.
Yes, madam.
Is it?
Yeah.
And when was this?
Uh,
On
18th of April, madam.
on 18th April. Right. Okay. And you assessed the patient a long time ago.
Yes, madam.
Is it?
Yes, madam.
Okay. So So you assessed the 3 seeds on 18th April. Okay. Fine. Patient was assessed. How many days after that did you assess roughly? 2-3 days after?
After 2 days, madam.
2
Initially, he was
days later. Okay. Yes.
initially he was admitted to the ward 45, madam. Then he was stayed for 1 day duration there. Then he transferred to ward 59, madam.
Okay. That's absolutely fine. Right. So you saw Mr. Ashen, who is a 22-year-old single mechanic from Chilau. He was referred by the medical ward. He had performed an act of deliberate self-harm, consuming 3 seeds of yellow oleander with some sugar on the 18th of April. You assessed the patient 2 days later. Right. So now you are going to, that was very clear, very well done. So now you are going to give us the history of the presenting problem. Is that right?
Yes, madam.
Yes, please go ahead.
He's a known patient with cannabis consumption since 2015. He was worked in abroad for 3 months duration in 2022.
Podakina. You may need to slow down a little bit because we are all taking notes. So 3 months in, worked abroad for 3 months in?
Dubai, madam. Dubai.
In which year?
2022, madam. This year, early.
Dubai. Gihan, your signal is very poor. See if you can either move or improve that in some
Madam.
way.
Madam, can you hear me now?
It's much better now, Gihan.
Okay, madam.
It's much better now. So your patient, Mr. Ashen, has worked abroad. Give me 1 second. I'll just get my daughter to stop streaming whatever it is she's streaming. Okay, so right. So at my end also, I have done the best I can. Let's go on. So Ashen worked abroad for 3 months in Dubai. When was that, Gihan?
In 2022, madam. Early 3 months.
Right. Okay, I get it. All right. Please go on. Okay.
And then he returned to Sri Lanka again. And on returning, he had a conversation with his mother, who is working in abroad. And mother asked him to stop consuming cannabis, but he had refused.
Okay. Okay.
They had an argument, and mother blocked him on WhatsApp. And he had no contact with her 2 weeks duration. Usually called mother every day.
Okay.
Following this, he was sad all the time and had lack of energy, low mood, didn't feel like playing the guitar, which he used to love most, and he had feelings of hopelessness, worthlessness,
Mm-hmm.
And these feelings progressively increased.
Okay.
And during that time, he used cannabis. He still used cannabis.
Right.
Um, and also he had pessimistic views of future, no plans. He didn't want to achieve things for his future. So on, madam.
Mm-hmm.
Mm, After the returning to Sri Lanka, he worked in Kurunegala private company. Uh,
Mm-hmm.
in the boarding place, one day in the boarding place, when no one around, he had attempted cutting his forearm with a broken window glass to reduce his sadness.
Okay.
And usually he visits home twice twice a week, once or twice a week.
Mm-hmm.
And he came back to home and he had to wear long sleeves to cover it up. But his grandmother noticed it. And during this episode, uh, he has had strong belief that his actions are posted on FB page as a story.
Okay.
Mm. And he thinks his life story being published.
Mm-hmm. Mm-hmm.
Uh,
Yeah.
he complained and talked with his friends, but they were laughing at him. And
Mm-hmm.
then he felt more worry about everything.
Which. Mm-hmm.
Um, on his birthday, which is on 18th April,
Mm-hmm. Yeah.
both parents have not wished for his birthday. Usually
Right.
they wish him every year, but this time they didn't wish. Uh, Around 12 p.m., he automatically walked toward oleander tree and plucked 3 nuts.
This is 12 noon, neither.
Yeah, madam.
Right. Mm-hmm.
And he didn't have any idea why he did so. Uh,
Mm-hmm.
but he waited till evening for them to wish.
1 second. Right. Uh, yeah.
Meaning, he waited till evening for them to wish, but they
Mm-hmm.
didn't. So then he walked outside the house in the garden.
Mm-hmm.
He ingested 3 seeds of yellow oleander with sugar out of sadness around 6 p.m.
Okay.
Mhm. Um, Before he consumed it, he heard female voice called him, "Come to me, come to me." But he didn't give any clear idea about that, madam.
Mm-hmm.
Only he heard that, and during that action, he knew oleander is poisonous and lethal,
Mm-hmm.
and he done it alone, and no one noted his action, uh,
Mm-hmm.
and no suicidal note written. No,
Mm-hmm.
no regret right after the action.
Okay.
But then after 5 minutes, he called to father and told about the act. Father apologized and then he felt regret. Then father called to his uncle and admitted him to Chilau Base Hospital. Then there activated charcoal given to him and also saline infusion was given.
Okay.
At the hospital, he had swallowing difficulties, abdominal pain, headache, chest pain, dizziness. 4 time vomiting episodes were there.
Mm-hmm.
Then thereafter, he was transferred to the NHS.
Okay.
And he has no ideas about someone trying to harm him. And he denies new thoughts were inserting into his mind. And he denies
In පුතා, no ideas of someone trying to harm him or මොකද ඊළඟට කිව්වේ?
he denies new thoughts insert into his mind or withdraw from him.
Okay. Okay.
And he denies hearing people talking about him when he is alone.
Mm-hmm.
And
Okay.
no history of over happiness, overspending money, or increased energy.
Okay.
Or wearing bright clothes time to time.
Mm-hmm.
In family history.
So this was your second part was your section on the past psychiatric history, isn't it? Yes.
Yes.
All right. Okay. In family history, go on.
In family history, his mother is working abroad and father is working at Nuarelia in a construction site, and he lives with his grandmother.
Mm-hmm.
And no family history of suicide or mental illness, but father consumes alcohol.
Okay. Mm-hmm. Okay.
In personal history, he has had a normal childhood and development history, but during his nursery school period, mother and father separated, and mother went abroad. But both of them are actively involved in his school activities and his educational life.
1 second. Gihan, can you give me a minute? This is Dr. Radhika from the board.
Okay, madam.
I'm sorry about this disturbance. Just give us 2 minutes, okay? I'll finish this call and come.
Yes, madam.
Okay, අයියෝ මගේ whiteboard එකක් නැකිලාද? Probably, no? God help. Okay. All right. Okay. So, Gihan, you managed to tell us up to the point where you said his father was a building contractor, that his mother works overseas, that there was a parental separation during early childhood, and that he was brought up by his grandmother. I can't remember anything beyond that, if you told me.
Yes, madam. But both of them are actively involved in his school activities and his educational life.
Okay.
And he got 3 C's and 3 S passes for O-level examination. After that, he followed NVQ course.
He got how? 3 C's and
3 S passes.
That's at O level, neither.
Yes, madam.
O level, and then okay, right? Then NVQ course, okay, in
and NVQ course, after graduating from that, he worked at Suzuki Motor Company for 2.5 year duration. After that, he went Dubai and worked there for 3 month duration in several companies. Currently, he works at hybrid mechanics in a motor vehicle company in Kurunegala. He earned for 45,000 rupees per month and not dependent on parents.
Okay.
In forensic history, no court or police cases.
Okay.
On sexual history, he has experienced multiple sexual contacts in Dubai, used protection, but no screen for sexually transmitted infections.
Okay. Okay.
In substance history, in 2015, he is in 11th grade. With school friends, he initiated consumes of cannabis.
Okay.
Then thereafter, he addicted to it and he used every day. And he used his education fees and job salary to buy cannabis. Initially, it was 1 packet per day, but with the time, it increased to 2 to 3 packets per day. And when he is in Dubai, he stopped using cannabis because of lack of connections. During there, at the beginning, he develops withdrawal symptoms, but not in severely. So he tolerated by himself.
Okay.
And he used ice only once in his lifetime.
Okay.
And he consumes alcohol occasionally.
Okay.
And he smokes cigarettes since grade 11, 2 to 3 cigarettes per week.
Per week?
Sorry, madam?
Per week?
Yeah. And
Okay.
but in Dubai, due to cheap and availability, he smokes 6 cigarettes per day.
Okay.
After returning to the Sri Lanka, he started to use cannabis again. Last used date was 17th of April.
Okay, good. Okay.
In past psychiatric history as above, madam. Past medical history, he had hemorrhoids. Treatments have been done. And past surgical history, he had undergone appendicectomy in 2013 under general anesthesia. He is not allergic to food, drugs, or plasters.
Good.
On pre-morbid personality, he is like to sing songs and like to play guitar. During school time, he played in a band also. Also, he liked to listen to Pirit and Bana. And he is very close to grandmother. And he's a friendly person. And he seeks attention, especially from loved ones. And he is a very affectionate person.
Harida, history ivarayda.
Yes, madam.
Okay, good. So positives first. There were lots of positive things to say about this. I felt that you had covered everything that was important. Okay, Gihan. But perhaps I could structure that same history a little bit more so that we have a little bit more clarity. Okay, so it is important, even if you have written it down, to speak clearly. It's okay to pause occasionally to look up and look at the examiners if it is in situ, because not only do you want them to hear everything you are saying, but you also want them to understand and take in what you are saying, because you may be, anywhere within a lineup of anywhere between 6 to 8 to sometimes even 10 students being assessed on a given day by a given panel. So we need to make sure that this is actually going into their heads, because it is what they processed rather than what you said that is getting marked. But you did a good job. Now, essentially, based on this, so there's given that this particular patient, the mental state won't make a huge difference to the diagnosis, shall I ask here and now, shall we, what is your preferred working diagnosis or else your differential diagnosis for this patient, Gihan?
I think, madam, it is depressive episode with suicidal ideations.
Anything else you'd like to add to that?
Psychoactive substance use.
Okay. Anything else? That's it.
Schizophrenia. Like.
So your differentials are schizophrenia.
Yeah.
Okay. That's all right. No problem. That's fine. You want to add anything more?
No, madam.
All right. Fine. No problem. Receiver, is it receiver?
Yes, madam.
Receiver, did you manage to hear what Gihan was saying?
Yes.
Well, I'm a
Yeah. Yes, madam. I'm on the way to the hostel.
Right. Okay. Hari, api oya hostel eකට යන්නකො එහෙනම් මේ කවිත්.
Yes, madam.
Kavit, were you able to hear what Gihan was presenting?
Yes, madam.
Right. So he did a really good job. I'm just trying to keep the rest of you involved and make sure you don't nod off. This is no criticism of Gihan. So Gihan mentions here, as I have put on the screen, you should be able to see also, he describes this as a depressive episode with suicidal ideation. Can you maybe polish that a little bit more? Depressive episode with suicidal ideation, can you name that same thing in a slightly different way? Depression can be mild, can be moderate, can be severe, can be with or without psychotic symptoms. Can you
Madam, it's a severe depressive episode with psychotic symptoms. with suicidal ideations and suicidal ideations.
And
Suicidal ideation.
active suicidal ideation. Okay, I might even, thank you, Kavit. Good job. Right, now, Risira, you must make yourself known at whatever point you get back to the hostel. Pasan. Hi, Pasan. Were you able to hear what Gihan was saying? Okay, how can we improve or polish up a little bit more what he mentioned, psychoactive substance use? Tell me how we can put that in a nice way. Now we know what the substance is also, for example, the substance is cannabis, neither. Okay, so what type of cannabis is that? There is a cannabis, he's using cannabis. So, eka mokhadda eka wenna puluwan, either it can be harmful use, neither. Or there can be substance-induced psychosis, of course. Nattang it can be harmful use of cannabis. It can be cannabis dependent syndrome. What does it sound like? Good job. Thank you. Now, as we have discussed before, there are 6 features of dependence, right? You need to have any 3 concurrently within the last 1 year, at least if you can find 3 within the last 1 year. So withdrawal is 1, tolerance is 1. So ekai dekai. Then we have, what are the others? There are 2 C's, isn't it? Severe craving, loss of control and inability to cut down. If I write them here, let's use another color now. Okay, so you're actually doing very well. Huh? This is fine. I'm just using this to revise here and there also. Okay, so the features 6, it was all 6ers, isn't it? All the dependence class was all 6ers. So we talked about tolerance, we talked about withdrawal, we talked about craving. Sorry. We talked about craving, we talked about loss of control to cut down, and there were 2 more. What were those? What was the last one? Anelamai. What was the last one? That's right. That's right. Harm. That is continuing despite evidence of harm. So there, you and I might say smoking 3 cigarettes a day or 5 cigarettes a day for 10 years is harm. You are damaging the bronchial epithelium. You are increasing your risk of COPD and lung cancer. You are increasing your risk of erectile dysfunction, ischemic heart disease, all those things. But the man who is smoking the 5 cigarettes for the past 10 years daily may not see that as harm, because other than a very mild cough in the mornings, he doesn't have anything. So, despite evidence of harm. So now we want 3 of these during the past, ideally 3 concurrently within the past 1 year, to identify anything as dependence. And I told you, as Kavit correctly said, that generally if anybody has had withdrawal symptoms, that is fairly likely that they are having a dependence. And in this patient, Gihan clearly mentioned a progressive increase in use, suggestive of tolerance. There is withdrawal, There is a severe craving, which is causing him to continue despite harm. Even the broken relationship with his mom is harm. No, after all, he has lost the ability to control or cut down. So there is evidence of cannabis dependence here. Okay, so that is there. Let's see if I can delete that little bit. Okay, so that is there. You could even say that this is with comorbid harmful use of nicotine. Gihan, did you remember to ask him whether he chose beetle?
No, madam, he's not chewing beetle, madam.
ඒක ඇහුවද?
I didn't ask, madam.
Okay.
But no features.
Okay. So we can see, you get staining of the teeth, all of that. That is true. I agree with you. But remember, especially from this background, it's a little bit more rural, isn't it? It's a community where there is, after all, yellow and also, it is a possibility. So it is one to bear in mind, because sometimes it's a little unusual to just smoke 2 to 3 cigarettes a week. One possibility is that the rest of the time there is rather a large amount of tobacco which he is chewing. Okay, right. So I may even have reworded this whole. So when my examiner asks me what the diagnosis is, I might have even said this is a patient presenting with an act of deliberate Okay, so yes, I agree with you, Kavinda. Is it necessary to mention the act of deliberate self-harm? Perhaps not. As in, can I put it this way? So Kavinda's question, thank you for putting it so that the others can see it. Kavinda's question, if you can look in the chat, is do we need to highlight about this self-harm? Given that anyway, we are talking about the active suicidal ideation in the severe depression, etc. Okay. If, given that this presentation, he takes the Kaneru or the yellow oleander, he tells his dad, he is admitted, he is transferred, he doesn't go to cardiology, because the intervention has been early enough that he doesn't develop the bradycardia, he doesn't need a pacemaker, none of that happens. But given that that was so central to the presentation, I would probably say that. This is a bit like, when I teach you your medically unexplained symptoms, we talk about, however much, say, a patient comes saying, I feel very weak, I'm having lots of body aches and headaches, and comes to the OPD, and we decide that it's all secondary to an ongoing episode of depression. We still need to manage those physical symptoms which the patient came with. So likewise, this was so central to the presentation that I held on to it. Okay, maybe you don't have to do that, but that was the reason that I did it. Okay, now I'm going to slightly so that is my answer to that question. Now I'm just erasing a few things to give myself a little bit more space. So that was our diagnosis. Now, given that that was the diagnosis, I'm going to try to, by memory, since we have lost that first bunch of slides, I'm going to try to maybe modify that history a little bit into a way that I would have presented it. Okay, now remember, your long case is not only about ability to elicit information, it is also about how to be able to present that information. So you have to elicit the information, you have to present the information, you have to be able to process the information to make a good problem list and management plan. And of course, which is how you develop your differential diagnosis, etc. Now, remember that presentations are performances, and it is practice that makes perfect with any performance. Okay? Whether it is case presentation or drama or music or dance or any other manner of performance, it is practice that makes perfect. So you have to present. Use every opportunity you get to present. Listen to each other present, because we all make the same mistakes. Okay? Theory knowledge, of course, guides your management, your problem list, how you process the information, all of that. But presentation skills also, there's a certain amount of marks for how you manage to present that. Okay? Which is why case discussions, case presentation and discussions are so central to effective, or shall I say successful, clinical examination outcomes. Okay, so don't give up these opportunities. It can be a little bit boring to listen to each other. Sometimes I've noticed students find it poor use of time. It is not poor use of time, it's very good use of time. Now, I am going to try to say, what is the word? Develop a mind map. I can't really develop a mind map here, maybe, but let's try to see what the main components of Gihan's patient were. Okay, so it starts off with a presentation about an act of self-harm, isn't it? So we are going to have to describe that act, isn't it? We are going to have to describe the act, including its precipitants. Now, deliberate self-harm always involves suicidal intent and suicidal risk, right? There are two things. Every act of deliberate self-harm in the psychiatrist chambers is discussed around suicidal intent and suicidal risk. So suicidal intent relates to the act committed. Suicidal intent relates to that act of consuming 3 seeds of yellow oleander with sugar on the 18th of April. Suicidal risk involves the current risk of suicide. Okay, so these are the things that we are going to talk about in relation to that act. Then if there was, I'm teaching, then if there were, then, so that's about the act itself. Then if there is, as Gihan described, any related mental illness, that might be, what are the common, so Deliberate self-harm is a presentation, no? It is not a diagnosis. Deliberate self-harm is nowhere in the ICD. So what are the related psychiatric disorders? What are the related psychiatric diagnoses that relate to DSH? කවුද අර මේ රිසිර ඔයා තාම පාරේද?
Yes, madam.
Are you still on the road?
Yes, madam.
Okay, all right. Now, who's next? Pasan, did you speak? Okay. So then who's after Pasan? Kaviduni, it's you, right?
Yes, madam.
Hari. So what are the other diagnoses that could be, what are the other psychiatric diagnoses that could be underlying this seen in a patient with self-harm? But it's the most likely one, then even dementia කියන්න පුළුවන් ඉතින් එහෙම නැතුව.
Associated with psychoactive substance abuse.
Okay, I'll take that. Psychoactive substance use, all right. Who's after Kaviduni? Is it Kavisha?
Madam, schizophrenia with psychotic symptoms.
අපි schizophrenia කියලා ඉමුකෝ. schizophrenia වල psychotic symptoms කොහොමද තියෙනවනේ. Okay, thank you. Nilushi, what is this?
Could be anxiety disorder.
Anxiety disorders තියෙන මිනිස්සු නම් self harm කරනවා හරි අඩුයි. ඒ කියන්නේ panic disorder වලට agoraphobia තිබ්බ කියලා ඒගොල්ලෝ මේ ගෙට වෙලා ගුලි වෙලා ඉන්නවා මිසක් මැරෙන්නේ නැහැ. So it's not anxiety disorder, it's something else. Who can help out? But anyway, thank you for trying, Nilushi. That's okay. It's okay to make mistakes, no? Right? At least you tried. Okay. Chamodi or anyone. What is this?
Depression, madam.
Depression, what the Q one putta? Depression is the first one.
Personality disorder.
What AD? Is it okay? All right.
Yes.
But what? What the Q? Yes, anyone? Didn't hear. Thank you. Thank you. Yes. Exactly. Patients with patients with anxiety disorders, patients with OCD, they don't actually tend to commit a lot of self-harm. Okay, anxiety disorder, OCD, they tend not to commit a lot of self-harm. Okay. Hasni, eating disorder involves a certain amount of harm to your body. But when it comes to practically, yes, I would agree with Buddhini that borderline personality is very high on my list, right? So if I were to make this list, I would have really been thinking about, obviously a lot of things can, but is it depression? Is it adjustment? Does this relate to yes, Panchali. So depression, adjustment, borderline personality disorder or traits, alcohol or substance. So these are probably the commonest. I agree with you. Self-harming can be commoner. There is a risk of self-harm in post-traumatic stress disorder. There is a certain amount of self-harming associated with dysphoria in bipolar affective disorder. But in actual clinical practice and in mockies, you will find that these are the most common. Either it's, in fact, I would say even above depression in actual, if you were to actually just look at the, if you were actually going to take 100 patients with deliberate self-harm who walk into Ward 59 and then just make a tally chart of what their underlying psychiatric diagnosis was, I think adjustment would come even above depression. Adjustment disorder, borderline personality, which I have misspelled, depression, alcohol or substance. These are probably the 4 most common. And these are usually, your Mocky station of self-harm is usually one of these. Because, while it is possible to have self-harm in post-traumatic stress disorder, while it is possible to have self-harm in that type of thing, it is not actually, what is the word? It's not that common. So when I'm saying, what I'm referring to is if you take a population of 100 people who have committed self-harm and who are referred to psychiatry, that is not very common, partly because PTSD is not very common. OCD patients don't tend to self-harm a lot, okay? Anxiety disorder. So anxiety disorders can be another panic disorder, social phobia, agoraphobia, specific phobia, generalized anxiety. Those also tend not to self-harm a lot, okay? So yes, it is possible for patients with bipolar affective disorder to commit acts of self-harm. That also more typically during the period of depression. No, the bipolar depression, it's the depressive episode that they are more likely to commit self-harm in. No, understood? So these are probably the commonest. That is important, right? So the next thing I am going to do is to, in this management of this patient, I am going to look at the presentation, all of that, the related mental illness. That is very, very important. And here, because there is the psychoactive substance is very closely linked, is linked to his problem, I am going to bring the substance history, also give that also more prominence. Another very important thing which wasn't mentioned actually, Gihan, is whether or not he has ever committed acts of self-harm in the past. Harida? Eka තියෙන්න ඕනේ. දැන් ඔය මේ ටික තමයි history එකේ, this is the backbone. These are the important parts of this history. And this is what I would bring up. Now, with your permission, can I go on for about, no, let us put a poll. එතකොට ඔය ළමයි නැත්තම් බයයි උත්තර දෙන්න. Now see if you can answer this. Don't feel obliged to answer in any particular direction. Tell me how you feel. I am perfectly comfortable. I am not going to get distressed by whichever way you answer it. Koani. මේක කී දෙනෙක් ඉන්නවද? 33ක් ළමයි ඉන්නවා. $23 තව ඉන්නවා. 25 තව ඉන්නවා. 27 Okay, so 29 of you have answered within the first minute. Right. So can you see the results? Yeah, you can see the results. There you go. So actually 4 people said preferably not. Maybe what we'll say is if you want to leave, go ahead and leave. I mean, it's a holiday. Tomorrow is also a holiday, etc., etc. But for the others who wanted to listen, I will finish this. Ashfa, I'm sorry. I know tomorrow is Eid. You are welcome to leave at any point if you like to, and I will keep this as short as possible. Okay. Now, what I'm going to do is I am going to try to present what Gihan presented to you. Okay. So I am going to try to present that. Okay. Now listen. I examined Mr. Ashen, a 22-year-old single motor mechanic from Chilau. He had committed an act of he was referred by the medical ward following an act of deliberate self-harm on the 18th of April. I assessed this patient 2 days later on the 20th. History was obtained from the patient. No collateral information was available to me. Okay, let's go on. On the 18th of April, which was Ashen's birthday. So now can you see, I am starting, I agree with Gihan that the problem starts with the conflict with the mum. But I am going to first finish with this act. Because why? Because I want to make sure that this examiner and all present listening are clear about the act, because I want to highlight this suicidal intent of the act. And based on that, based on the suicidal intent and the mental illness, come to the possibility of suicidal risk. So I'm going to start with the act for this reason, okay? So on the 18th of April, which was Ashen's 22nd birthday, he was experiencing sadness relating to the fact that neither of his parents had called to wish him on his birthday. He denies having had any prior plans of committing an act of self-harm. However, has plucked and saved up 3 yellow oleander seeds around noon, which he finally took about 6 hours later, together with some sugar, in privacy without the awareness of anyone else. Kavit has I'm so sorry. My apologies, Kavit. Ashen Ashen denies any clear suicidal intent or wish to die associated with that act. However, he admits that he believed that 3 seeds of yellow oleander, especially taken in conjunction with sugar were highly likely to be lethal. He had not performed any final acts in preparation for impending death. And shortly after ingesting these seeds and sugar, became remorseful, or perhaps not remorseful, but chose to divulge his actions to his father, who then made speedy arrangements for medical assistance to be provided. At my assessment 2 days later, Ashane did not express significant regret about his act of self-harm. Appearing to be somewhat ambivalent about his survival. Okay, pause. So in other words, I have talked about what the act was, what immediate precipitant for the act was, whether there was planning, so what the act was, what the immediate precipitant for the act was, whether there was planning. I have told you what his view of the lethality of that method was. Then we talked about preparation and final acts. Any particular precautions taken for concealment, avoidance of disclosure, acts to maintain concealment, locking a door, going into an area, going to a location of privacy, etc. And whether there were about the subsequent disclosure. Now, in his case, the subsequent disclosure is very prompt. And finally, it ends up with regrets about the act and, ambivalence, relief, or regret regarding survival. Some people may be relieved that they have survived. Some people may be regretful they have survived. Some people may be ambivalent that they have survived. Okay. So then I talked about that also. Okay. So I have finished with that act. Initial primary medical care was provided at Base Hospital Chilau, from where he was transferred to a medical ward of the National Hospital Sri Lanka, where he has received monitoring. He has not required specialist cardiological intervention, and received a psychiatric referral on the second day after admission. That's the act of self-harm covered. Ashane has not committed any acts of self-harm. Sorry, there was one. My apologies. There is one act of self-harm in the past, in the recent past, which I will describe shortly. Either you can now say that within the last 3 months, Ashane was experiencing a lot of sadness, and on one occasion chose to self-harm by cutting his forearm with a piece of glass in an attempt to numb or distract himself from the sadness he was feeling. Or you can leave it to tell later, because it's also going to get discussed in the depressive episode now. So I would now mention that Ashen has experienced persistent sadness with a low mood, with a lack of pleasure in previously pleasurable activities, a lot of regrets regarding his past, anxieties regarding his future, a sense of pessimism, worthlessness, and hopelessness. Gihan, you did a good job of describing that when you presented this patient, which has been present for at least 2 to 3 weeks. What you did not mention, Gihan, was whether this was associated with disturbed sleep, loss of appetite, reduced levels of energy, attention and concentration, and impact on his occupational functioning. If he is sexually active, you could mention whether libido was affected also. Okay. So that is something that could have been described. And then I would have probably said, Ashen has no past history of mental illness. And the current symptoms, which were just described, of low mood and pessimism, hopelessness and worthlessness, appear to have developed since his return to Sri Lanka from the Middle East 3 months ago, apparently precipitated by a significant deterioration in his relationship with his mother, who had in fact blocked him on WhatsApp and not been in touch for the previous 2 weeks, following a dispute regarding his cannabis use. And it is during the past, it is 3 weeks ago or 10 days ago or whatever, that this act of self-harm by cutting himself has happened. Okay. So actually still I have not said much about his cannabis. Okay. But since it is so very relevant, probably, generally, anything that is highly relevant, you can bring it up. You don't have to wait to keep it, under wraps till you get to the personal history. You can easily present it now. Okay. So for which reason I will mention that Ashen has been consuming cannabis daily. And this has caused significant conflicts with his mother, who has been very critical of this, and his inability to cut, and his not having cut down or abstained from this habit. Ashen reports having begun cannabis use while in the 11th grade, around the age of 16, with peers, and cannabis use has gradually increased over time, with him requiring 1, subsequently 2, and then even 3 packs of cannabis to obtain the same amount of pleasure that he did in the past. Now I have taught you explained about the tolerance also. Ashen has never willingly abstained from cannabis, except during a period overseas, during which he was not able to access a supply. And at this time, he has experienced unpleasant symptoms of withdrawal, such as difficulty sleeping, a sense of irritability, headaches, and inner restlessness. He has never, as I mentioned, willingly abstained, nor has he sought medical assistance. He has clearly had strong craving for the use of this substance and has lost the ability, lost control to cut down, and continued despite evidence of harm, such as the significant impact on his social relationships, namely that with his mother. In addition to cannabis use, Ashane smokes cigarettes and reported smoking just 2 to 3 cigarettes a week. And additionally, and denied any additional use of nicotine in the form, chewed nicotine in the form of tobacco, dried tobacco leaf with betel chew, etc. He has once, on one lone occasion, experimented with methamphetamine or ice, and denies ever having used other party drugs or heroin. He consumes alcohol in the form of beer and arak occasionally on social occasions, but has never consumed so much alcohol as to have lost consciousness. So now I have really talked about his substance also, no? Okay. I have mentioned up to that point, which I feel is necessary. As mentioned previously, there is no self-harm or significant mental illness except those within the current episode, which I have just described to you. I would generally then mention his past medical history and say he has no history of thyroid disorders or epilepsy. He has undergone appendectomy under general anesthesia, and apart from having had some treatment for hemorrhoids and PR bleeding, has no significant medical or surgical history. He has no food, drug, or plaster allergies. Ashane has no family history of mental illness, with no family history of suicide or psychoactive substance use. His father consumes alcohol regularly, occasionally, or appears to have heavy alcohol use suggestive of dependence, is something I would say. Remember, the family history is neurobiological. The social things, whether his father is a building contractor or a member of parliament, those things are social history, okay? Right. I also don't know, but I assume that Ashane is the only child of his parents. Okay, so that also comes into it. So I have finished the presenting problem, history of presenting problem, past psychiatric history, family history, medical history, surgical history, all is over. If there was a woman, I should have mentioned the menstruation, which was not relevant here. Because the psychoactive substance was so integral to the presentation, I have brought it up. Now I'm going to talk about his personal history. It appears that Ashane has had a relatively safe and happy childhood with and he's not aware of experiencing any significant physical illnesses or problems with growth or development in his early childhood. And he has, however, his parents have separated when he was in his early childhood, when he was 4, 5, 6, 7, whatever years old, after which his mother has moved to live overseas, leaving him in the care of his grandmother, maternal or paternal grandmother, who he describes as a loving, caring person with whom he maintains a close relationship. In other words, his caregiving was sustained. He had a good primary caregiver. That needs to be mentioned. Okay. Then what do we say next? Ashane attends school. His highest educational quality, he's leaving school in the 11th grade, having passed his O-levels with 3 C's and 3 S's, and then completes an NVQ course in motor mechanics, and begins working. He has a good occupational history and works in Dubai for the short period of 3 months. Why he curtails his overseas work in 3 months, we don't really know. Currently, he is employed as a hybrid motor vehicle mechanic in a private company in Kurunagala, where he is paid the sum of approximately, where he can earn a total of about 45,000 rupees per month. And he resides in a boarding place closer to his place of work, although he is originally from Chilau and visits Chilau in the weekends. He has he currently does not have an intimate relationship. He is primarily of heterosexual orientation, and has engaged in casual sexual encounters with protection in the past years, but does not appear to have ever maintained a stable intimate relationship exceeding several months or weeks. He has there is no significant medical, legal, or forensic history. There are no police complaints or court cases against him or placed by him. And he is not in debt to anyone. His substance use has been very central to his life. And he admits to even having diverted money given to him for his tuition, his after-school tuitions, towards funding this habit, which he engaged in with friends. He either does or does not continue to have a close-knit circle of friends, and with whom he does or does not share his personal problems. He tends to become quite impulsive when faced with problems, or he denies being impulsive in the face of problems, tending to think carefully before responding in situations of difficulty. His money handling is good or poor. There isn't really a lot in this history to suggest that he's dissocial in any sense. And of course, with regard to his premorbid personality, he describes himself as sociable and enjoying the company of others, being primarily a follower rather than a leader, and somebody who does not engage in much adventurous or novelty-seeking behaviors, apart from having initiated and maintained cannabis use since the early age of 16. He even describes himself as a somewhat religious person who respects his parents, his elders, and his religion. Although he does not appear to find much solace in his religion in times of difficulty. I think that is more than enough. Okay, so that's probably what I would have said. Do you have any questions on that? Okay, no questions, fine. So that is what I would have said, right? Now, Gihan, can I trouble you? Is Gihan here? Has he disappeared? Gihan, are you there?
Yes, madam.
Gihan, since your patient, now this is not only a deliberate self-harm, there is a depression also, no? Shall we present the mental state and then stop?
Okay,
We
ma'am.
can discuss the management of severe depression when we do the affective disorder cases, but shall we present the mental state?
Okay, madam.
Yeah, go ahead.
On appearance and behavior, he is averagely built man and well groomed, wearing t-shirt and short. His right ear and not wearing earrings. There is a tattoo in his left forearm, and I could there is a multiple superficial scars on left forearm, and I could build good rapport with the patient.
Okay, so
And-
now that's really good. Okay, you really described that he's averagely built, that there was a piercing, a tattoo, superficial scars on the left, on the forearm of the non-dominant hand. That is superb. Just you can mention also that he was dressed appropriately for the occasion in a pair of shorts and a t-shirt or whatever he was wearing to complete the appearance, because you get marks for all these components, no? Okay, the next thing that you're saying when you move on to behavior is that Ashen was cooperative with me throughout my interview, maintaining, and then talk about the eye contact. So he was cooperative, presented willingly, cooperative, eye contact, ilangata rapport. Harida, eka kiyana gihan podda behavior.
Yeah, and he has a good eye contact throughout the interview, and I could build a good rapport with patient. And he's not anxious at that time.
He was he was outwardly calm කියලා තමයි අපි කියන්නේ. හරිද? Right, okay. Good. So you have done the appearance, behavior. Next thing is speech, neda?
Yeah.
What you going to say?
It was spontaneous and coherent and relevant.
Okay.
And rate, volume, amount of speech is normal.
So Ashen's speech was coherent and relevant. There was spontaneous speech, and the rate, amount, and volume were
normal, madam.
okay. Okay. Rate, amount, volume, to rate, amount. Yeah. What?
And no speech difficulties.
No speech difficulties. All right. Okay, I'll take that. Okay. Difficulties. All right. Okay. What's next?
In the mood, it was subjectively and objectively euthymic.
I would expand this nicely. His objective mood was neither happy nor sad. Euthymic කියන්නේ normal කියන එකට code word එකක්. හරිද? Euthymic is a code word to say normal. Euthymic කියන්නේ ඒක. So subjectively, his subjective mood has to be in layman's terms. Was neither happy nor sad, was neither unusually happy nor sad. Objectively, his predominant mood was euthymic. And go on, Gihan, even a monad kyan tiyeni mood ek gana.
That's it. Yeah.
So he's right. Now, if you have told us that this patient is having severe depression with mood congruent psychotic symptoms and suicidal ideation, puta, me mood එක එකත් එක්ක පොඩ්ඩක් පරස්පර විරෝධී. හරිද? එතකොට මොකද්ද මෙතන වෙලා ඇත්තේ? What do you think the problem is? Maybe you are looking at it up close a lot. It's not really a big error. Anybody else? What do you think? What is happening here? You know, the mood was euthymic. Then kata karanakota mood is euthymic. What are the possibilities here? So Gihan took a history, did a mental state, and we all made this differential diagnosis list where the working diagnosis was severe depression with mood congruent psychosis and thing. Mood is euthymic. Now, Hari, what are the possibilities here? Is this complicated? Anybody? Kolamai. Okay, so Kavinda, he was on treatment. Okay. Kavinda and benzodiazepines can, I suppose, reduce anxiety, but depression doesn't resolve in 48 hours, Naputa. Also, nobody would have started an antidepressant immediately, Doggala, because of the cardiac risks with that thing. So, agreed, accepted. One possibility is the treatment. But again, 48 hours. This is why I asked when you said 18th of April, when did you assess him? So, by the 20th of April, even an antidepressant, even a benzodiazepine shouldn't really shift the mood. අපි තව ටිකක් අහගෙන යමු about the mental state, then you all can think about my question while Gihan goes on. Okay, so it's the others who have to help us with the answer. Okay, so mood was predominantly euthymic නේද Gihan? ඊට පස්සේ
Yes. On thought, he thinks that his actions are posted in FB page, so delusion of reference was there. And other than that, no delusions and no suicidal thoughts at the moment.
okay.
Only that, madam. On perception, there is no auditory, visual, or somatic or tactile hallucinations.
Okay.
On cognition, he is well
Cognition එක අපි මේකට වෙලාව ගන්න නැතුව යන් cognition then ඊළඟට එන්න ඕනේ මොකද්ද? Insight. හරි. හරි. Then now we'll give Gihan a break. දැන් මට ළමයි කියන්න මේ මොකද්ද මේ වෙලා තියෙන්නේ මෙතන? Okay, so one student has offered, it is easier if you guys put it for everyone to see. Okay, so one student, since it was put as a private message, I won't say who, one student has suggested a patient might not be expressing sadness during the interview, although at other times he may be sad. Now in depression we talk about persistent pervasive sadness. And of course, I agree with the sentiment expressed, which is that even the depressed person may not be depressed 100% of the time. Particularly if the intensity of that depression, if it's a less severe episode, for short periods of time, they may be okay. You know, when they are coming to, when they are coming to work or when they have to meet somebody, පොඩි වෙලාවකට ඕක cover up කරගෙන වගේ ඉන්න පුළුවන්. Echo, when the grandchildren are visiting or when playing with the child or something for a short spell of time, that mood can improve. But generally, it's pervasive, persistent, right? You don't generally, especially, remember again, like I said before, the mood has an emotion or a sadness component which we feel to our heart and soul when we assess the patient. There is cognitions of pessimism, there is somatic aches and pains, and there are certain behaviors which are associated with such as the lethargy, the downturned face, the tear-filled eyes, the vertical furrows on the brow, the drooping mouth, all of that, the hunched shoulders, the hunched posture, all of that, right? So is it likely that a severe depression, a patient with an ongoing severe depression is not expressing that depression during the mental state examination? That's a bit unlikely. It's a little bit unlikely, but good thinking on the part of that. Okay, so that was one. The treatment also we said in 48 hours, it's not going to lift. No. So මොකද්ද මෙතන වෙලා තියෙන්නේ? මම දැන් 20ට ගැනලා උත්තරේ කියනවා. ඊට කලින් කියන්න. Why is it that in the mental state examination, in the psychiatric interview, right? So the whole thing took some time now. In the psychiatric interview, why is Ashayan not depressed? What is the possibility? What is the other differential diagnosis that probably it was? Come on, guys, you can do this.
Not having using psychiatric substances at that moment. So,
මට තේරුන්නේ නැහැ පුතා. ඒ කියන්නේ?
In the hospitalization, after the hospitalization, he is withdrawn from the substances. So
from the cannabis, okay. එතකොට
No.
So what you're saying is, the mood was associated with the psychoactive substance. It was not a depression. It was just the cannabis intoxication. And now it is gone. So it is gone.
Yes, madam.
Okay. Okay, that is possible. But I think pervasive low mood එකක් with cannabis which stops when you end cannabis එකක් අපි theoretically එහෙම එකක් අපි දන්නේ නැහනේ. You know, let people get very low when they are using cannabis, and this man has been using cannabis from the age of 16. There's no reason for his mood to dip really low while he's on cannabis and then to bounce back after he stops cannabis. Ne? So that is little less likely. Yes, Kavinda, that is the thing. This is a depressive type adjustment disorder. Okay, so we have to talk about adjustment disorder because it is very much a big issue. This is a depressive type adjustment disorder precipitated by the conflict, the breakdown of the relationship with his mother, right? This is a depressive type adjustment, not a severe depressive episode. In adjustment disorder, self-harm risk is quite high actually. That is what this is. So that we'll talk a little bit about the theory of adjustment disorder again at another time. But that is basically why this is a depressive type adjustment disorder. Harida. Ekai then make with the, which is partly why evelema then high suicidal intent severe depression එකක high suicidal intent එකක් එක මට මැරෙන්න ඕනේ කිව්වා නම් ඔක ගිලලා ඉවරලා තාත්තට call කරන්න ඕනෙත් නැහැනේ. So that was also a little clue there, but that is how it is. හරිද?
Excuse me, madam.
Yes, Hasni.
Madam, can we diagnose adjustment disorder when the clinical picture fits into the criteria of depression?
Okay, good question. So I will talk about adjustment again later, but adjustment disorder can be, is what we call adjustment disorder. There's a bunch of slides on the LMS on stress related disorders. Okay. I would, if you have the time and patience, I would strongly encourage you to listen to that because that goes very, very step by step on why this is so. And this is explained there. But basically, adjustment disorder is when somebody adjusts and adapts poorly, does not adjust, maladapts to some problem. So the generating distress and or disability of a severity to call it a disorder, which is when it's adjustment disorder, not just some small reaction. You know, I failed an exam, I cried, that is an adjustment reaction, but I am really disordered by it. And the person, you know, the chronologically, the difficulties, the symptoms, the problems relate to this particular stressor. If that stressor is removed, the symptoms will automatically go away without any further intervention being required. There can be self-harming, there can be all manner of symptoms. And in fact, is there, now a little clue was there, Gihan didn't tell us about whether the functioning was, how the functioning was. Now, if this were a severe depression, the patient is not going to be functioning. Moderate depression and above, the patient is not going to be functioning. Chances are here the patient was functioning also, which is also a little clue. This is not actually depression, right? So when you're really going into the history, you know, you were very, very sad that mother is not speaking. You know, he's feeling guilty about his substance use. Had he really completely lost pleasure in all pleasurable activities? Had he actually given up even YouTube clips and FB and meeting his friends and everything? Was it all gone? What about the biological symptoms of depression? the sleep, the appetite, those help to discriminate. The sleep, the appetite, the attention, the energy, etika. Then, this, again, it is just, mother doesn't call, father doesn't call, they don't love me anymore. It's not really that he has been having suicidal ideation off and on for the past so long before he engages in this act. Plus, in a psychiatric interview, if you have depression in a psychiatric interview, you will identify depressed mode. There will be depressed mode, right? There really does need to be depressed mode and cognitions. Pessimistic cognitions, depressive cognitions, hopelessness, worthlessness, when he described the thought. But the patient's depression should be here. One of the reasons it's a little difficult is because Gihan is also a student and he was also maybe a little bit misled by the whole presentation. But the discriminant factors for me would have been the things I mentioned in the history and in the mental state. In other words, currently here now, cross-sectionally, in the looking for that sad mood, ideally with a reduced reactivity. There should be pessimism, regrets, anxieties for the future. Speech also should be reflecting it, isn't it? There should be speech latency, reduction in speech, all of those things. And in the, he starts by saying how there was good rapport, there was cooperativeness, good level of eye contact. That is not in fact, if I were to, shall I do it this way? If I were to do an imaginary mental state of an imaginary Ashen who did have severe depression, it would probably go something like this. Okay, so on mental state examination, my patient Ashen was averagely built. He was appropriately dressed for the interview in a well-fitting pair of shorts and a polo neck t-shirt. I noted a piercing in one ear and a tattoo of a flower or a tattoo which mentioned or named his mother. There was evidence of superficial and recent healed scarring on the anterior aspect of the forearm of his non-dominant hand, his left forearm, which was symmetrical and suggestive of recent self-harming. He was wearing appropriate footwear and there were no abnormal movements. Ashen was calm and cooperative throughout my interview. Now I'm giving a depressed picture, no, sorry. Ashen presented willingly for interview and remained cooperative throughout. However, he avoided eye contact with me, maintaining a downward turned or downcast eyes, which I noticed to be filling with tears off and on. Tears rolled down his face when we discussed his recent difficulties and act of self-harm. There were vertical furrows in his brow and his mouth was downturned. His shoulders were hunched and he was leaning forwards. There was a reduction in gestural movements and in postural changes. Gihan's speech was coherent and relevant, and there was some amount of spontaneous speech. But there was an increase in speech latency and a reduction in overall amount of speech. And the amount of descriptive speech was very much reduced, with his speech mostly restricted to brief phrases in response to my questions. The rate of speech was somewhat reduced and his speech was soft. He described himself as sad and objectively, my assessment was that his affect was significantly depressed with reduced reactivity, restricted to the range of depressed to anxious. He was preoccupied with pessimistic thoughts, with regrets regarding his past, particularly his conflicts with his mom and his psychoactive substances, and anxieties regarding his future and the need to successfully abstain from substances. He had no particular plans for the future, which he could express to me, apart from rueful admission that he needs to come off his substances. He denied active suicidal ideation at this time and had no wish to hurt or harm himself or others, but also admitted that he didn't see much point to living any longer. So again, I'm interrupting myself to say mood and thought. The bridge between mood and thought is suicidal ideation, homicidal ideation, thoughts of aggression, okay? Apart from this pessimism, he continues to believe that his actions are being monitored and posted on Facebook and being discussed widely, which suggested to me both delusions of persecution and delusions of reference. He strongly believes he is a worthless person, suggesting delusions of nihilism. At the time of assessment, there were no perceptual abnormalities, and he did not experience hallucinations in any modality. And of course, we'd go on to talk about his cognitions where things would be there and his insight and so on. Does that help answer your question, Hasni?
Yes, ma'am.
So you wouldn't really see a severe depression, a patient with a diagnosis of a severe depression, a major depressive disorder currently in a severe depressive episode, with nothing in the mental state. These patients who improve very quickly, that is adjustment. There were lots of clues to say that this was adjustment, just starting off listening, but then that is with experience. Now I can't expect you all to have that. When the presenting problem, when you began to describe the presenting problem, my gut instinct was that this is adjustment. So, right. So are there any further questions that I can answer? People who need to leave. Ashfa, thank you for being here. Have a happy Eid tomorrow. Anybody who wishes to leave can go. Does anybody have any questions? I'll wait a second to check if there are questions. You can just ask. You don't need to waste time typing. Okay. All right. Enjoy your holiday tomorrow.
Thank you, madam.
Thank you, madam.
Welcome.
Thank you, madam.
Thank you, madam.
Thank you, madam.